Next presenter, Dr. Candido. He's been around with us for years. He's an amazing presenter. We enjoy his company every time he comes. He wants you to know that he's a professor of clinical surgery and anesthesiology at the University of Illinois, and he wants you to know that there are 3 more visits to Antigua available for sale. Anybody wants to bid on those, you still can. Welcome, Dr. Candido.
Good morning, everybody. It's extraordinarily difficult to follow the likes of Dr. Dewan and Dr. Centeno, 2 of the real leaders, especially Dr. Centeno with his seminal research on the use of PRP in bone marrow stem cells for managing chronic painful conditions. I have no financial disclosures as they relate to this learning activity. I am a professor of surgery, clinical surgery, and clinical anesthesiology at the University of Illinois College of Medicine. I was asked to talk a little bit about PRP versus stem cells, and there'll be, obviously, as I listened to the last 2 talks, there'll be some overlap, and obviously we didn't sit down, Dr. Dewan or Dr. Centeno or myself, and say, show me your slides, although Dr. Dewan did use some of mine a little bit. I have a private practice now. I'm at the Pain Center of Illinois. I've authored about 200 peer-reviewed publications. I've published 100 textbook chapters for enduring materials, and I've delivered 1,000 continuing medical education lectures and seminars. I was the chairman of an anesthesia department for 14 years, and I've run 2 separate pain management fellowships. I was the fellowship director at Loyola for many years and the fellowship director of pain at the Advocate Masonic Medical Center. So the learning objectives today will be very simple, and again, there'll be some repetition only by virtue of the fact that I didn't really know precisely what the prior speakers were going to discuss. Talking a little bit about a comparison of PRP to stem cell therapy in chronic pain conditions, talk a little bit about the potential for adverse effects, and what strategies might be available to improve our outcomes when we utilize regenerative therapies. I want to start off with a little clinical vignette. We are in Tampa. The Tampa Bay Buccaneers play here. We have a guy named Tom Brady. I heard Dr. Centeno say that nobody plays quarterback after 35. Well, Tom Brady played until he was about 80 years old, I think. And he had a center. His center is Ryan Jensen. I'm not violating any HIPAA laws by presenting this information. Ryan Jensen, on July 28th of 2022, so almost exactly 1 year ago, when the team met for their practices, was going through some drills, and he sustained a catastrophic injury to his left knee. He tore his PCL, his MCL, partially tore his ACL. He also tore his lateral medial menisci. And he was told by several individuals that not only would he never play professional football again, he might never walk again, and he was going to need multiple reconstructive surgeries of his left knee just to be able to be functional. Well, Ryan Jensen didn't buy that. He's an all-pro center. He's been Tom Brady's center. He's been a Super Bowl champion. And he searched out or sought out a different remedy. And the remedy was to contact the Prodromos Stem Cell Institute, which I happen to be a member. And he came down and received treatment. Again, I'm not violating any laws. This is public information by virtue of what Ryan has gone on to discuss. And he had stem cells injected into his knee, and he had intravenous stem cells. And despite the predictions or the forecast that he would never play professional football again, by January of this year, after having these catastrophic 6 tears in his left knee, he was out on the football field when the wild card game between the Bucs and the Dallas Cowboys was undertaken. So it just shows you, now this is obviously something which doesn't happen to everybody across the board, but it's a reminder of the amazing healing properties associated in many cases with the use of stem cells. So basically what we're doing with regenerative medicine is we're taking a catabolic state, essentially, and turning it into an anabolic state. We have all these interleukins, tumor necrosis factor alpha, and all these things that circulate, and we're trying to suppress them and to increase things like tumor growth factor. We're trying to bring in cells which can have a process of self-sustaining perpetuation and have this ongoing for a prolonged period of time. Now, anybody who does any regenerative medicine should be apprised of the downside, or what the dark side is, of some of the research associated with these technologies and techniques. Piero Anversa, who was at the New York Medical College in 2001, started to research in mice the use of bone marrow stem cells for the regeneration of cardiac muscle. And this came to the attention of Harvard. Harvard actually recruited him. Piero received about $50 million in grant money to study the effects of bone marrow concentrate in mice with an induced myocardial infarction. And they made several claims that bone marrow could regenerate myocytes, myocardial cells, which were injured during myocardial infarction. You can imagine that heart disease is the #1 killer of Americans, the intense scrutiny and interest in this process. Well, it turns out that the research was fraudulent and fake. And there were 31 papers that Professor Anversa had published. 19 were outright withdrawn. They were in journals like The Lancet, the New England Journal of Medicine. And it became a huge stain, not just on Professor Anversa, who obviously disclaimed any knowledge or disavowed any knowledge, stating that this was one of his research associates responsible for this. But it also left Harvard in a bind. They ended up paying many millions of dollars back to the federal government by virtue of this disclosure that the slides were fabricated, that the findings were not true. This is just something as a warning. Always look at studies with a healthy degree of skepticism. I do. Even studies that seem to have undergone intense peer review. Here's me in my own clinic with my PRP setup. I do PRP, I do stem cell work, typically offshore. Many of you are staring at the right bicep. That's actually natural. I haven't had any fillers or infiltrates put in there. So mesenchymal stem cells, and again, we've had great lectures on this from Dr. Dewan, Dr. Centeno. Basically, to be classified as a medical signaling cell, mesenchymal stem cells must possess 3 properties: be capable of division and self-renewal for a prolonged period of time, be unspecified, and give rise to specialized cell types. And so, obviously, what we're doing is we're trying to change a catabolic state to a relative anabolic state. And mesenchymal stem cells, unlike PRP, are functional at lower levels of inflammation. So PRP has been described as being very useful in inflammatory conditions, whereas stem cell use, whether it's bone marrow, adipose, placental-derived, Wharton's jelly, what have you, those cells have been found to be of greater utility in chronic degenerative conditions where there's little inflammation. The sources, again, bone marrow, well studied. Dr. Centeno is a world authority on this process, but it also can be derived from adipose and some organs, including the placenta. And I've worked with Gustavo Moviglia from Argentina. He's got a laboratory in Buenos Aires. And yes, the viability of certain cells is reduced, especially over time, but recently harvested or freshly harvested cells from placenta, from Wharton's jelly, have been shown to be viable, at least in a substantial percentage of cases. Mesenchymal stem cells have been shown to induce endogenous stem cell activity. And again, the process, what we're trying to create is a regeneration of damaged tissue. And that has led to the development of new and ongoing therapies. So, do stem cells work, for example, for a fracture? Well, yes. Bone marrow is a multifunctional mixture of RBCs, platelets, and nucleated cells. And if you use it to heal a fracture in the knee, for example, there's evidence that supports this process, healing a fracture of bone. Bone marrow-derived stem cells can also improve cartilage function, where there's been a tear of cartilage. And growth, there's a variety of growth factors that assist in the healing and repair. Cartilage repair also involves growth factors and lends to the process of chondrocyte differentiation of mesenchymal stem cells. In the disc, the intervertebral disc, and again, Dr. Centeno has a great wealth of experience in this, is published extensively on this. It's been demonstrated that bone marrow derived mesenchymal stem cells can differentiate into the nucleus pulposus. And that's really a fascinating topic. A little bit controversial, but still fascinating. The levels of evidence in support of this, you heard Dr. Dewan talk about discal injections of both PRP and bone marrow derived mesenchymal stem cells, is about level of evidence 3. And I'll go through a retrospective summary of the literature that we had available to us in about 2020 from the American Society of Interventional Pain Physicians when we published our systematic review of regenerative medicine in just a moment. So in disc injections, this is a study of Wu, found in 6 studies there was a 44.2 point decrease in pooled pain scores with discal injections of stem cells. There was also a 32.2 point improvement in the Oswestry Disability Index. So it wasn't just pain that was improved by stem cell discal use, it was also functionality. That's very important. That's an important concept, is not just to use a subjective metric to determine whether a therapy provides benefit to our patients, but also, are they able to be more functional or not more functional? And again, there's level 3 evidence using the classification internationally agreed. Hip disorders. Stem cells derived from bone marrow have been shown to improve osteonecrosis of the hip. There's been evidence by MRI of regeneration in the hip. Chawla showed us that hip osteoarthritis was also improved by bone marrow-derived mesenchymal stem cells. Knee osteoarthritis appears to have the highest level of evidence using systematic reviews and meta-analyses, and that level is level 2 evidence. That's for both PRP as well as for bone marrow-derived mesenchymal stem cells. There's efficacy for cartilage repair in osteoarthritic conditions. This is really a great topic. Dr. Centeno published a randomized crossover trial of high-dose bone marrow concentrate versus physical therapy, showing excellent results compared with control. It's one of the seminal studies in our literature looking at this process and this phenomenon. Here's a patient study from David Noriega for intradiscal use, 24 patients, bone marrow-derived mesenchymal stem cells, 25 million cells injected per disc versus a sham control intramuscular injection, showing improvement both in pain as well as in functionality. Here's an adipose study. Again, we talk a lot about bone marrow and other sources, Borton's jelly, adipose bone marrow. This is a study from Lee, Kim, and Jim, showing adipose-derived mesenchymal stem cells for knee osteoarthritis, showing an improvement in pain and functionality with adipose-derived stem cells. Here's another study from Gupta, allogenic mesenchymal stromal stem cells for knee osteoarthritis, 60 patients, to look at a dose-response phenomenon, 25 million cells versus 50 million cells versus 75 or 100, because nobody knows the actual dose response. And it was seen that even in the lower doses of stem cells, 25 million versus followed by the injection of hyaluronic acid, there was improvement across the board in pain and Oswestry Disability Index functionality. So it seems that we still don't know precisely the exact dose required to improve individuals. Here's another dose-response study looking at 30 patients with knee osteoarthritis, either 10 million cells versus 100 million cells. It was a 12-month up to 4-year study, and again, we saw improvement in functionality in both the low-dose cells as well as the higher-dose cells given for osteoarthritis. Here's another one of Dr. Centeno's really important papers, I believe. He looked at 33 patients with low back pain, used bone marrow-derived mesenchymal stem cells, looked at improvements in pain and functionality, but really importantly also showed the MRI, 85% had a reduction in disc bulge size with the average reduction of 23%. So that shows not just an improvement in patient outcomes, but also an anatomical change associated with the use of these cells. Really important study. Here's a study that was again referenced by now. I'm the third person, Patine study, so I won't talk about it. Colony forming units of fibroblasts greater than 2,000 per ml and CD34 cells greater than 2 million per ml. And Dr. Centeno pointed out one of the downsides is waiting to actually be able to derive these values, but which showed that those values were somewhat important in determining functional outcome for patients. Here's a study from Kumar, adipose-derived mesenchymal stem cells. Again, a dose-response study of 20 million cells versus 40 million cells, and it appeared that there was no significant difference observed between the 2 doses in terms of outcome. This was published in the journal Stem Cell Research Therapy in 2017. This is one of the 2 papers that I was privileged to participate on in behalf of FSIPP. We published this in the journal Pain Physician to try to summarize what we knew at the time, and this again is a little bit old now, it's from 2020, for the use of bone marrow mesenchymal stem cells for managing all sorts of different types of painful conditions. And again, the outcomes were, as you already heard from Dr. Dewan, knee osteoarthritis shows level 2 evidence in its favor with the use of cells, whereas intradiscal injections was found to have about level 3 type evidence. And for facet joint injections, which I do perform, and for epidural injections, SI joint injections, the level of evidence was found to be 4, which is not very robust, but nevertheless provides a glimmer of hope that there may be improvement in our technologies over time. The Public Health Service Act of the FDA requires minimal manipulation under the same surgical procedure exemption. We all know about this. I would study this if you undertake to do regenerative medicine in your own respective practice. The next paper that I was privileged to participate in, again from Pain Physician, was to look at the responsible, safe, and effective use of biological therapies in the lumbar spine, i.e. discal injections of both PRP as well as stem cells. This was to provide some sort of guideline for that purpose. This may be one of the more important things I tell you the entire lecture, that for lumbar disc injections with PRP or mesenchymal stem cells, the levels of evidence are 3. Lumbar epidural injections, level 4. Lumbar facet joint injections, level 4. And SI joint injections, once again, level 4. These are all, again, as of 2020 when we synthesized this data and published this paper. And this shows you the 6-month and 12-month values associated with PRP injections intradiscally. If you look at 0 to the left of 0 means that it favors the use of PRP both for pain and functionality at 6 months and 12 months. And anything to the right of that would favor alternative and competing strategies. This is the use of cell therapy, again, for discal injection. Anything to the left of the 0 favors the use of cell therapy. And again, we see the data of cell therapy, not PRP, but stem cells. Anything to the left favors it. And we're looking at 6-month data on top, and on the bottom, we're looking at the 12-month data. I do want to talk just very briefly about one of the things that I do, which nobody on, I don't think, the planet Earth has done up to this time. We have many patients who've got refractory, recalcitrant pain from trigeminal neuralgia. We've taken them to one of our several locations overseas, and we've injected stem cells into the foramen ovale at the Gasserian ganglion. We put in 5 million cells per side. This is me with some of my colleagues, Dr. Romero, Dr. Prodromos, and myself. This is in one of our clinics. This is in Monterrey, Mexico. And we've now done more than a dozen individuals. I perform CT scan guided Gasserian ganglion injections with full sterile technique. You can see placing the needle under CT scan imaging. If you look at this rendition, this is now a 3-dimensional reconstruction of what we have when we place our needle through the foramen ovale into Meckel's cave. I don't always seek cerebrospinal fluid return when I do these injections. We do get sometimes paresthesias, but the beauty of doing a CT scan guided 3D reconstruction technique is that this takes me anywhere from 7 to 9 minutes per side to inject stem cells. And as I said, we've done about 7 patients already. Our success rates are 100% in terms of improvement. When I indicate improvement, I'm talking about a 50% or greater improvement in pain and functionality. This is another patient that I have with the opposite side. You can see the red circle indicates where my needle is entering the foramen ovale. I do not inject contrast. These are straight cells I aspirate and inject. And again, these have taken me on the average 7 to 10 minutes per side. So in conclusions of our research, our review, remember to always remain in compliance with the Food and Drug Administration when you conduct any of these types of therapies. Dr. Centeno talked about this. When we're practicing in the United States, and obviously make sure the patient has a requirement for biological therapy. Just a brief passing, because there are other alternative ways to extract cells, and we've heard some of the skepticism about the viability of cells, but there's a nice study that came out from Samara about Wharton jelly, mesenchymal stem cells used for knee osteoarthritis, which demonstrated up to 12 months improvements in pain functionality, as well as some MRI improvements in the structural nature of the articular injections into the knee. So are there any contraindications to the use of cells, whether it's PRP or stem cells? Obviously there are contraindications. Hematological dyscrasias, platelet dysfunction, septicemia. However, malignancy, which was formerly thought to be a relative contraindication to the use of cells, has now come under scrutiny, and I'll show you that on the next slide. Allergies, if the patient has a severe psychiatric impairment, clearly, or any genetic abnormalities. Infection, tissue rejection and changes, initial worsening of pain. I always caution patients, especially with a lot of these peripheral joint injections that we do, they're going to be miserable for several days, whether we're injecting cells, primarily cells more than PRP. And that's really a phenomenon that requires them to understand they're not going to use non-steroidal drugs. We typically treat that with ice application topically and the use of tramadol only and acetaminophen. Here's a multi-center analysis of more than 2,300 patients using mesenchymal stem cells for musculoskeletal conditions. After 9 years, only 7 patients developed a neoplasm, which is lower than the rate of neoplasia in the general public. So they previously adhered to dogma that we ought to be doing stem cells or regenerative medicine in patients who have a potential for cancer is probably unfounded at this point. Current strategies. Procedure should be performed under direct visualization, whether that involves the use of fluoroscopy or in the cases of, like I do with trigeminal, under CT scan imaging or ultrasound guidance. Avoid corticosteroid use for up to 2 to 3 weeks, NSAIDs for up to 1 week. It doesn't really matter what gauge needle you use. Some proponents would insist on using larger bore needles like an 18 or 19 gauge, but there's really no difference in cell viability if you use a 22 gauge needle versus, let's say, a 19 gauge needle. I do use smaller syringes for all my injectates, about 2 mLs, to avoid overinflation, but again, the size is consistent with that used in currently successful studies. Post-procedural recommendations, again, immobilization. We used to say, when I first started PRP, I would try to immobilize people for 3 or 4 weeks. That's really untenable. Now, for a minimum of 2 days and for up to 2 weeks, and follow up every 2 to 4 weeks, which is appropriate. However, frequent repeat imaging is not recommended. I'm not really looking for structural changes, although there are some studies and some evidence that that may occur in the discal space as well as in the knee. When to consider regenerative therapy, and you heard Dr. Centeno talk about this, it becomes cost effective over time. The initial expense, however, may be prohibitive to certain individuals. When things like NSAIDs, rest, have not been beneficial, or in the case of somebody like a professional athlete where surgery is found to be a condition which is unsustainable or untenable for them to continue in their professional career, and when there's been a failure of conservative therapy. So I went over by about 1.5 minutes. I apologize. Thank you very much for your time and attention.